This is our session. Ready to record? Great. This is our session on minimally invasive surgeries. We're very honored today to have two neurosurgeons with us who specialize in minimally invasive procedures. The first is Dr. David Adelson, who is the Chief of Pediatric Neurosurgery at Phoenix Children's Hospital and the Diane and Bruce Hale Endowed Chair for Pediatric Neurosciences. He received his undergraduate medical degrees at Columbia and completed his neurosurgical residency at UCLA, which is why lots of interaction with Dr. Mathan here, who was at UCLA. When he was awarded the A. Leland Albright Endowed Chair as Professor of Neurosurgery, Pediatric Neurosurgery at the University of Pittsburgh and Children's Hospital of Pittsburgh before he went to Phoenix Children's. Dr. Sandi Lam is a member of our board of directors. She is a pediatric neurosurgeon and a leading specialist in the areas of pediatric cerebrovascular surgery, epilepsy surgery, and craniofacial surgery with a focus on minimally invasive and endoscopic techniques. In addition to her clinical experience in complex surgeries, her research focuses on quality, outcomes, and healthcare utilization for children in neurological surgery. She regularly lectures nationally and internationally and is recognized for her work globally. She is the division head of pediatric neurosurgery at the Ann and E. Robert H. Lurie Children's Hospital. Welcome, Dr. Adelson and Dr. Lam.
Alrighty, thank you, Monica, for the nice introduction, and it's great to be here. And it's great to share a podium with Dr. Lam, and then obviously to see old friends, which is wonderful. So we're going to speak on minimally invasive epilepsy surgery, and so I'm going to give an overview and then move into kind of how we do the diagnosis and treatment of patients with medically intractable seizures. And so just as an aside, I do some consultancy with Medtronic and LivaNova, which makes the VNS, but I will try to keep it generic for you all. As you've heard throughout this conference, epilepsy surgery has been around a long, long time, actually dating back to the 19th century. But it's really been published mostly in adults, and while good outcomes have been achieved, the biggest problem has been, how do we target children where this is obviously a significant neurological disorder and a significant population of patients. The biggest challenge is identifying the origin of the seizure syndrome, and so when we start to talk about minimally invasive approaches, we really have to be considerate of the concept as whether this is going to be a very small area of focus that we have to be concerned, or is it going to be something that's more broad? And that's really where the diagnosis comes in, and that's how we decide on the optimal surgical approach. My takeaway points are that the best outcomes come when we're able to accurately localize those seizures in the seizure network. There's a lot of innovations in diagnosis as well as innovations in minimally invasive surgery, and then really this combination of approaches which can allow us to hopefully get better seizure outcomes for these patients. I know you've all heard this before, really after a first drug, about 50% of patients will be seizure-free. A second drug, only another 11% will become seizure-free. And then we now starting to have diminishing returns when it comes to this, such that there's about a third of patients who remain unfortunately medically intractable who would potentially be candidates for epilepsy surgery. If we look at the total problem here, when we have an epilepsy prevalence of about 3 million in the United States, that means that there's about a third of patients that are medically intractable, and we're only doing about maybe 7,000 to 10,000 surgeries per year. And so the reality is that there are a substantial number of patients who are not receiving adequate treatment. And unfortunately, the average duration of refractory epilepsy for some, particularly when we talk about adults, is oftentimes around 20 years. And so where do we go from there? I mean, the goals of epilepsy intervention, no matter whether it's medical therapy or surgical therapy or dietary therapy or alternative treatments, it's to stop the seizures. And the reason for that is we know that the seizures will cause some brain injury to the brain. It will cause interference of normal brain function. And when dealing with children, it will interfere with normal development. Now, whether that's due to the seizures or the toxic levels of medications often needed to control the seizures, these are really what is problematic. And so we need to assess, the brain activity and function, really with the goal to try to understand where normal is and where abnormal is. And by being able to identify those areas that are abnormal, hopefully we'll be able to then target our surgical treatments. And I'm going to focus obviously on the surgical treatments. Well, a lot of this has come about because of our innovations in imaging. The MRI has been able to show us multiple abnormalities. Here's an old MRI on the left, and then with different sequences, one can appreciate now cortical dysplasias, which now potentially give us targets. And with increased analyses, we can start to look at cortical thickness changes, and so we can see comparisons to those. And here's just a picture of the brain with an overlay of the subdural grid and depth electrodes, but also where there was cortical abnormalities in this patient. But the reality is that epilepsy is a functional disease, and so we really need to be able to target functionally where those abnormalities are. And there's a number of different modalities, and most of you are familiar with those. But what I think is exciting is really the frontier is the concept of coming up with less invasive procedures for us to identify the functions of the brain and where the abnormal functions may be. Many of you are familiar with functional MRI, which, at least for adults, is starting to potentially supplant older techniques in identifying abnormal areas. And one can appreciate here in motor networks to see where it is in relation to lesions. But really for children, the reality is that functional MRIs are not able to be done. And so resting state functional MRI, which can be done in a sedated patient, to be able to pick up areas of both normal networks as well as abnormal networks. And so we can identify, at least in this particular patient, an area of abnormality in the left temporal lobe because of the abnormal network that one can appreciate. Just as an example, again, now if we take all of that data and start putting it together, we can take a much more multimodal approach for diagnosis. And so you can see here the number of tests that were done in this patient in order to sort of bring together a potential hypothesis for where we might perform surgery. Well, there have been a lot of innovations, and again, we're going to focus on the more minimally invasive ones. As I can attest, when I trained with Dr. Mather, this was what we could do back in the 1980s, and things have progressed over time. We no longer were doing anatomical hemispherectomies. We went first to subtotal hemispherectomies with disconnections, where we were doing quote-unquote functional hemispherectomies, and now we do hemispherotomies. And so more and more we can do more minimally invasive approaches, and then as well we can start to include things like laser ablations in order to be able to attack or to try to cure areas of abnormality. And then similarly, neuromodulation has come on, and this has really started in the 1990s and then progressed over the last few decades in order for us to be able to really help a growing number of a population of patients. Well, just sort of moving into really this minimally invasive approach, laser interstitial thermal therapy has now been around for at least over 10 years. Some people call it stereotactic laser ablation. And ultimately, it's about placing a laser probe into an area of abnormality, being able to heat the brain and be able to observe that in real time in order to determine whether we're able to either ablate a lesion, melt it in more kind of common terms, or if we can neuromodulate that by disconnecting or damaging that tissue or damaging that network so it doesn't no longer propagates and causes the more generalized seizures. The great thing is that obviously for a single focus or a very targeted focus, this particular minimally invasive approach has really come on the scene and been really quite helpful for a multitude of patients. Here's an example of one of our patients. This was a 14-year-old young girl from Hawaii who had had gelastic seizures since 6 months of age, but interestingly only recently came to evaluation. And at the time that I put this together, she was neurologically normal, and she did have normal development, but unfortunately she was having about 6 seizures per day. She was tried on a multitude of medications with really no impact, and eventually was sent to us for further evaluation. Her EEG was non-localizing, and a lot of her other studies were not localizing, but one can appreciate here, this is her MRI, and you can see the arrow pointing at the hypothalamic hamartoma, which is really just a small ball-like lesion in her, located as part of the hypothalamus. It's really a collection of abnormal tissue that really has no function, unfortunately, except to cause seizures. In this image, especially with our ability to really get much more granular and be able to see much more targeted areas, these arrows on the right are pointing to the mammillary body, so you can see the proximity of that lesion relative to a very important structure, which is really for memory function. So this is a very targeted area, and an area that we would, it would be very difficult to try to go in and do an open surgery or an endoscopic approach. Here's just looking at different images of the same, so the hypothalamic hamartoma on the left, and then the mammillary bodies and the fornices on the right. Well, in this case, we used resting state functional MRI because we were looking to see if we could target where the connections were from that hypothalamic hamartoma, because we really didn't want to heat that whole hamartoma because we could potentially risk damaging the mammillary bodies. Fortunately, this resting state was able to show us that the connections were over the top of the lesion and pointing posteriorly, or points toward the back. So you can see here, this is the laser probe placed into the HH. You can see that we placed it towards the back. And in fact, we didn't ablate the whole HH, but rather just where the connections were that showed us where her seizures were occurring from. So you don't have to take that whole lesion because it's a benign lesion that won't grow. We just took the connections. This child has been seizure-free now for 2 years. And so when we take a look at these things, we don't necessarily have to take the lesion, we just have to take the area that's causing the seizures in these patients. Well, the wonderful thing about having a hammer is you start to look at things like everything's a nail. Here was a patient, this is a 17-and-a-half-year-old young woman. She had been having seizures for a long period of time. Really, all of her data seemed to point to her left temporal lobe. Interestingly, and we were very pleased that her language dominance was on the contralateral side. We did do her EEG and all of those PET studies, and it all pointed to the left temporal lobe and really in the amygdala and hippocampus. And here you can see the final damage maps using the laser ablation, and we were able to place this probe, do an ablation of just the mesial temporal lobe in her, and this is just the DWI, the diffusion weighted imaging after surgery, showing what and the extent of our ablation, and then this is our contrasted study, which also shows the extent of our ablation. And this child also was seizure-free postoperatively. The nice thing about this type of procedure for a very targeted approach is that both of those children went home the next day. They don't even go to the ICU, which is in contrast if we had done this as an open procedure. Usually they stay a day in the ICU, they spend a couple of days at least on the ward, and then potentially, they can go home. They're usually laid up for a couple of weeks, and so this has really been a nice addition. Well, again, you got the hammer, more nails. We've been able to do similarly if we can target where there are abnormalities. Here was a patient with a frontal cortical dysplasia. In this particular case, you can see the extent of the ablation we did. This required 3 probes, and usually we'll do not much more than 3 probes because it does cause heating in the brain, it does cause swelling, and so we do have some concerns about possible morbidity with that, and so we like to do it in a very targeted way if we can. In this patient, you can see the extent of the arrow? No. You can see the extent of the enhancement, but you can also see kind of where we were able to sort of limit our ablation. Well, again, got that hammer, got to do more nails. This is a patient, a 6-year-old with Lennox-Gastaut, with a number of different seizure types, as y'all are familiar. In particular, though, was the atonic seizures, and these were particularly devastating as this child was injuring himself, just falling out of the blue. The child was in a helmet, had broken open his chin multiple times, and knocked out his teeth a couple of times. So, indeed, this child really was, in peril to himself with the significant seizures. As you can see, he was tried on multiple regimens. The quote on the vagal nerve stimulator was that it was a loser. It was actually doing well for his general eye. All of the meds in the Epidiolex were helpful for his other types of seizures, but was really not taking away the major problem for this child, which was the atonic seizures. In an open procedure, this is what we would be looking at. We'd be doing a small incision in the bone at the top of the head, and I think Dr. Lam will talk about ways that we can approach the corpus callosum using the endoscope. This was in the pre-endoscope era. This is what we would see under the microscope. Here would be a case where we could disconnect the brain and be able to do the corpus callosotomy in patients. Well, in the appropriate patients, those with more favorable anatomy, we could consider doing this with the laser ablation. And so this was a patient who has, you can see the corpus callosum is this white area band right along the middle. I'm sorry, I can't point to it. I'll walk over for a second. So this is the corpus callosum here, and you can see my arrow pointing to it on the coronal images. This is a favorable anatomy for corpus callosotomy using the laser ablation. Here you can see the damage maps for the genu, but this requires 3 laser probes for us to be able to do this. So here's one in the front, where we did the ablation in the front. Here's another one coming from behind, but then covering the front portion of the corpus callosum. And then the last probe, which is extending through and covering the posterior one. Now, these are the damage maps. You can see the DWI afterward. And again, this is an instance where really very favorable anatomy allowed us to treat this child's atonic seizures. I'll just quickly go through neuromodulation. I know that others have covered this area, but I just wanted to highlight that really this is a very, very important area in epilepsy surgery. We are recognizing that we can interrupt seizure networks, particularly across broad areas. So when a more minimally invasive target is not able to be obtained, we can still do more minimally invasive approaches and surgeries in order to try to improve things. And so that's where you need to weigh the risks and the benefits of trying to stop the seizures. There are a number of different modalities, and I know that others have spoken about this throughout the weekend, but suffice it to say is that I'd like to highlight that the vagal nerve stimulator is not really surgery. It is a brain pacemaker, for sure, but it is one in which the neurologists are changing the frequency and the dosage of it, and really the risk-benefit for these patients is truly immense. And I cannot highlight that enough. It's a procedure that can be done in 45 minutes. They go home about an hour or two after the procedure. In many instances, meds can be lowered, especially if there's a real response, and particularly in children. And in some instances, they can come off meds. Rare, but possible as a possibility. The new generations are somewhat closed loop in that they will record from the heart rate when there's a seizure that's possibly coming on, and then give an extra stimulus. So almost in some ways has supplanted rescue meds in some patients. So again, the new generation vagal nerve stimulators are quite effective. And now there's long-term outcome data that really shows that you can get a 50 to 60% improvement in seizures, which is really significant when you consider that a new medicine really only has about a 1 to 4% chance once you get beyond 3 meds. Similarly, RNS has come on in the last few years. This is also an implanted device, a little bit more complex, and I would give it that. But again, it's an area that, and I know that Dr. Abel spoke earlier in the conference. This is really a new horizon in children, but we're seeing really such nice results. And again, I won't belabor it, but suffice it to say that, again, we're placing electrodes right in the area where the abnormal network is, and what we're trying to do is interrupt that seizure network from propagating and becoming a generalized seizure. So it reads the seizure and then readmits electrical stimulation to try to stop that. It can be a fairly extensive procedure or a more minimally invasive one, depending on your perspective. But again, depending on the patients that are being treated, it's still pretty significant with regards to those that have no other options for treatment. At least in adults, there are very good results and a long history, and I think now you'll start to see it in children going forward. Similarly, with deep brain stimulation, again, another area that's been shown to be effective in adults, but we've started to use it as a hybrid in children. This was a 15-year-old young girl who unfortunately had an autoimmune encephalitis. She was unresponsive to meds. She underwent all the non-invasive procedures that looked like she had multiple foci. She underwent the SEG electrode placements, and you can see the extent of that here, as well as the brain imaging. We used high-frequency oscillations to be able to understand where her more frequent seizures were coming from, and there were in a couple of different locations. One was in the area of the amygdala, and one was, or a couple were more on the left side of her brain. So we did a hybrid, which included a surface electrode and a depth electrode in the thalamus and the central median nucleus. And here you can see her recordings. You can see the activations in this child, where those electrodes were, this had a significant impact on those activations. Now, unfortunately, we only had 2 electrodes that were placed in her. So while we got good control of these electrodes, unfortunately, she still had seizures, though it was improving at her last visit. These are just the outcomes that we had with the RNS in a paper we most recently presented. So just for neuromodulation, I just want to highlight that we know that epilepsy is potentially fatal, and so it's very important that we get some control of the seizures, and whether it's through minimally invasive approaches or in this sort of neuromodulation era, I think that indeed we should be considerate in all of those patients. So lastly, we know that intractable epilepsy impacts mortality, morbidity, and quality of life. We also know that outcomes from surgery are better as compared to continued failed medical therapy in select patients. And so it's not for everybody, and we recognize that. But what's fantastic is really that even an old dog like me can learn new tricks. And about every 2 years I have to learn something new, which is, I think hopefully keeps me young, and we'll kind of go from there. But those innovations and advancements, I think you'll see that over the next few years will continue to grow, and we really do need to be able to share this in the pediatric population. You know, clearly I couldn't do it without a great team, and we've got a wonderful group in Phoenix, at Phoenix Children's, and I've had the privilege of working with everybody here to do that. So thank you very much.
All right, so this is I'm really just thrilled and honored to be here with this group and with patients and families, and to follow Dr. Adelson and just be among people that I really respect and admire. So this is kind of part 2 to talking about minimally invasive epilepsy surgery. These are my disclosures. The top part is research grants. I'm a health services researcher and also do global neurosurgery. Actually following in Dr. Adelson's footsteps, because he's actually an international neurosurgery rock star for all of the global neurosurgery federations. The other are industry-sponsored studies to mainly partner with industry to try to make instruments better, right? So that we actually have better hammers. And then, so really to follow up very similar themes, and I'd love to reiterate that epilepsy is a big deal. It extends beyond seizures, right? And seizures are things that you live with every day, and it is a journey, and a very scary journey. But also to public health, that is a big deal to the healthcare system. And it's not just direct healthcare costs, like how much it costs to do a surgery. It's also caregiver-related costs, right? How much do you have to give up in your professional life and your job, and to have to go to doctor's appointments and to actually get all of the care that you need to try to get the best care for your loved one. And also there are consequences like premature death, right? Sudden unexpected death of epilepsy. And also other seizure-related accidents and a higher rate of suicide. So seizures are actually very common, and we are pediatric neurosurgeons, but also it really spans across the lifespan. And when you look at how epilepsy surgery is delivered, we are getting better and better at surgery. We have a lot of different offerings. But really, Dr. Adelson alluded to the treatment gap, which by estimates in epidemiology, about 1 in 3 children who can benefit from epilepsy surgery are actually getting surgery. So that's actually the basis of a lot of my health services research, is why the treatment gap and how can we do better. And there are lots of questions that we ask all the time about how can we do better, is how can we help more patients? How can we do better surgery? How can we do surgery in a more timely manner? And how do we develop better tools and do the surgery more safely and effectively? So Dr. Adelson talked about the rationale for epilepsy surgery, and it's not just to stop seizures or seizure freedom. It's to reduce seizure burden and improve quality of life. And even when we feel like the localization of where the seizures are coming from or why patients are having seizures may not be something that we could say we're going to have a cure, we still think that we can try, right? For palliative reasons, try to decrease the seizure burden and really try to improve the quality of life for patients and families and communities. And in children, the timing really matters to capitalize on the developing nervous system. So I do use the imagery of the toolbox and different instruments that we have, and this is kind of typically, how the workup for seizures and a journey happens, right? Where you have primary care doctors, you have neurologists, and you have a comprehensive epilepsy center that can help with the workup, and then eventually you meet the scary surgeon. But really, I would say that shouldn't be the paradigm. It should be that surgeons, social workers, neuropsychologists, neurologists, like everybody should be all in the toolbox together, and we are just part of the armamentarium and the things that we use to fight seizures all together. And that surgery is not a last resort. There's been a lot of innovation over the past couple of decades to really make surgery accessible and possible and actually appropriate for patients that actually in training that we would have never actually been able to offer surgery to or help patients with surgery. And now we actually have different options. And that's very exciting, and it's very humbling because we are kind of part of this evolution, and it's important for us to be curious and to learn techniques and to also kind of understand our role. And this was the most recent publication out of the ILAE that talked about the timing of referral for epilepsy surgery, and really speaks to the theme that surgery is not a last resort. It's actually something that we should consider much more quickly and much earlier in the epilepsy journey than traditionally is happening. So if lesional epilepsy, even after one medication, should already be referred to surgery, and really anybody up to age 70 in like reasonable health or thinking about surgery should be evaluated for surgery. So I've also looked at this from a national data and insurance data standpoint. So it's not looking at who gets to go to elite centers. It's actually who all comers for children with epilepsy or intractable epilepsy. If you are on medical treatment or surgical treatment, how does that actually look? And when we compared kids on medical treatment versus surgical treatment, at up to 5 years after kind of this decision point, the kids treated with surgery actually had lower rates of emergency room visits for seizures or not seizures, and actually were on fewer anti-epileptic medications. So, in that standpoint, surgery isn't so scary, right? It can actually give you better outcomes and better quality of life. So what are the things that make surgery scary? Blood loss is actually one of the most common perioperative events that can happen in epilepsy surgery, so how can we do better? And I think that's kind of part of the role of the minimally invasive surgeries. And the other is to think about where we fit into the spectrum of all epilepsy surgeries. And I'm mainly going to focus on disconnective surgeries here, and that's where we really developed some of the endoscopic approaches. And Dr. Adelson talked about the role of laser surgery for epilepsy, which has really revolutionized the field and revolutionized how safely and effectively we can do things. Now, I'll talk about something that is also in evolution, which is when you look at the traditional craniotomy, which is that kind of larger question mark shaped incision in red, to now a much shorter, smaller line and much smaller opening in the bone. We're able to use that type of opening and the use of an endoscope, which is really just another tool, right, for us to be able to look inside and make sure we can do surgery safely. And there's a few different types of disconnective surgeries that I'll talk about, but that's really the role for the endoscope. It's not the end all or the be all. It is a tool that we can use to do surgery smartly, safely, and effectively. And I'll talk about kind of my evolution of the understanding of how we can use this tool well. And one is for corpus callosotomy. We've looked at this type of example with Dr. Adelson, which is at first we learned it all open, right? Which is with an open craniotomy, and it's up at the top of the head, and you get to this midline structure. And when we look at the corpus callosum, everybody's corpus callosum is a little bit different. Some are a little bit thinner and more flat, and some are a little bit more curvy. So when you look at MR-guided laser ablation, Dr. Adelson showed the laser fibers, and they're all straight, right? So you'd have to think about the geometry for how to actually use straight things to produce a burn in a straight way. And you can do that. And there is, as Monica talked about, there can be some swelling or kind of heat that you have to think about over time. So there can be a little bit more swelling than you would like if you have a really kind of fat and big and kind of curvy corpus callosum. So in my former practice in Texas, we looked at this and thought about if we did open craniotomy, corpus callosotomies, or laser, how does that impact, how long you're in the hospital, if you need to go to rehab, and what happens. And when we looked at that, we realized for some patients there wasn't really any clear benefit, right? Because some patients actually really needed to go to rehab and had to be on a lot of steroids depending on how the laser ablation is done. So we thought, well, is there something kind of in the middle where we can look at what we're doing in surgery, not have to use a laser, but not have to do a really big cut? And that's actually how we evolved into the role of endoscopy and using kind of a little flashlight, if you will, and I'll show you a picture of that. There are different ways you can use it. I call it a three-hand technique. You may have heard of neurosurgeons doing brain surgery through the nose to get to pituitary tumors, and we use the endoscope in that way as well. So there's a lot of adjuncts and a lot of tools that we use to try to make sure that that surgery is safer and that we set ourselves up for success. So we use neuronavigation, which I call kind of like GPS for the brain, so that we can plan our opening. And this is the endoscope. I use a straight endoscope, and the navigation we can actually put on the endoscope as well. You'll see it's actually a relatively small cut on the skin right up top, so you don't have kind of the big swelling that can happen when you get a big incision. Also, you can have post-operative imaging techniques like DTI or tractography to look at your disconnections. So if we can reach the midline structure like a corpus callosum, can we do hemispherotomy, and does that make sense? And Dr. Mathan really taught me about the whole evolution of techniques for hemispherotomy, and really what is, what are the things that we really have to do inside, right? So you can really cut any which way, but you still got to do the same things on the inside in order to be effective. So these are kind of different types of hemispherectomies or hemispherotomies with a lot of different names over time. And this is actually from Dr. Mather's paper showing the evolution towards a functional hemispherotomy of the UCLA technique. But when you break it all down, this is actually what you need to do on the inside, which is to cut your corpus callosum, disconnect your corona radiata fibers, disconnect in a frontal-basal disconnection, and then also your mesial temporal structures. So in evolving to a smaller opening on the outside, we don't compromise what we do on the inside, right? We're still doing all of the same cuts. So minimally invasive does not mean minimally effective. It means we want to be maximally effective, we just want to be minimally invasive on the outside. So these are the cuts that I make from the endoscope up top, which achieves all of the 4 disconnections. And we still use the navigation, and our position in the operating room is that we make a little cut up top here. And then the setup in the operating room, because we're relying on the endoscope, we actually have to look at our screens. It's like a little bit like a video game, but we have to make sure that we can see everything. In the range of cases, we can do everything from hemispherectomy for a perinatal stroke, which you can see there's a lot more fluid, brain fluid, so there's more room. So if you are thinking about a tool that makes a very tiny effect, like a little laser, maybe if you have a lot of room and just a little tiny thing to disconnect, or to very full brain, like a whole hemispheric type of problem like a hemimegalencephaly or cortical dysplasia. So when we first developed this technique, we were very careful to follow everything to make sure that we were maximally effective and that we could achieve the same outcomes as an open hemispherectomy in the way that I learned it from Dr. Mathern. So this was our first 3-year follow-up series. And you know, I was looking at our at the rate of shunting, and this will go along with a international study that I'll show that really looks at like all comers, you know, any technique. Are there any techniques that get you better rates of VP shunting after hemispherectomy? And all comers, it's about 20 to 25% rates of post-hemispherectomy hydrocephalus, whether you go lateral or vertical or any way that you cut. To date, when I follow my first 40 endoscopic hemispherectomies, I'm at 8%, but there's a big but and a big asterisk because I showed you my first 12, right? I was at a 25% shunt rate. So is it that I don't have long enough follow-up yet and that I will get to that 20 to 25% shunt rate? I don't know, right? Because we've all seen that, you know, we might need a VP shunt after hemispherectomy in 1 week, in 1 month, in a year, or maybe 10 years out. So, so I am optimistic, but I don't know. So when you look at my seizure outcomes from this technique, it is as good and commensurate with open craniotomy series. I have been able to keep kids from needing blood transfusions or needing to go to the ICU as long as they're over 2 years old. Our average blood loss is about 30 to 50 cc's. So in a school age kid, I actually don't worry anymore. But for a small baby, I'm definitely very cautious and book the ICU and make sure that we're ready for blood transfusions. So for the post-hemispherectomy hydrocephalus, this is something that I'm looking at very carefully because we know that any technique that has been reported internationally when we've pooled results together, nobody can say that they're doing better than anybody else. Even though you ask any surgeon, like, we gotta believe that what we do is what we think in our own hands the best that we can be offering to our patients, right? So so I think we really need to keep each other honest and share our outcomes and see what transpires over time. So when I look at our endoscopic assisted hemispherectomy, we can be safe. We have good seizure outcomes that are as good as any other surgeon reporting outcomes in the world. We've really minimized our blood loss and really enhanced that recovery time where patients can start working with therapies from the first day after surgery, because the cut looks almost like the top of a ventriculoperitoneal shunt. It's about a 4 centimeter incision up at the top of the head, so you don't get that big kind of question mark shaped craniotomy where you get that swelling in the face and the swollen eye and the painful chewing. We kind of skip all that. And then the other thing that I don't know about yet, but I started out with the big open craniotomy telling everybody, because that was the way Dr. Mathern taught me, you're gonna have fevers, like really bad fevers, don't worry about it, we got this. You're gonna have a pretty bad headache and a really bad stiff neck. And somehow we've skipped this with the endoscopic hemispherectomy to the point where now moms and dads are like, you told us we were going to have a fever. Where is it? We don't have it yet. And I realized there might be something to the way that we access the brain and the ventricle where we are cutting through less brain. So we are seeing much less of that, where patients typically don't get a stiff neck anymore and fevers are really, really uncommon. So also as a surgeon, I think it's important to be curious and learn. And I've had different visitors come learn the endoscopic technique in my operating room over time, and they've pushed me in different ways and said, you know, there are different ways that you can do tips and tricks to be slicker, and have these little shortcuts. So actually my frontal basal disconnection, I learned from other groups. So Dr. Sean Liu, who Dr. Mather taught hemispherectomy to, came and watched me and told me that a Japanese group taught him this modification, which I've now adopted, and it takes off about 30 minutes from the operating room time. So I think really collaboration is really important. And then really thinking, are there other ways that we can apply these techniques when it's a good idea and when it's safe. So just mentioning posterior quadrant disconnections, which typically would take a big opening from the side, either a question mark or a T-shape, where you have to stay away from the motor strip. We're able to do that through 2 small burr holes now, and do that through the endoscope as well. So minimally invasive still needs to be maximally effective. So I think for any families who are working with your surgical team, I think it's absolutely fair to ask, is this safe? Is this a good idea? Is the anatomy favorable? And Dr. Adelson talked about this, which is, just because you can do it, doesn't mean that's the best idea ever. So is the anatomy favorable for this technique? Does it make sense? And try to see if the surgeon's done a lot of planning, because it's actually our job to worry. We may not fess up, and we might not tell you that we worry, but we worry a lot and we plan a lot, and we actually have a lot of contingency plans. And I think it's okay to ask, well, what if you can't reach that? What if you can't see that? Because we usually have a lot of answers. And I think that really can help you understand that you're in the right place, right? That you have that level of trust. And actually all surgeons, as they are developing and innovating, have resources so that we can learn to do better and better. So we have access to anatomy labs, a lot of different kind of imaging and planning, and now virtual reality and 3D printing. So a few kind of take-home things is that we have a lot of expanding strategies to do pediatric epilepsy surgery kind of better and safer, but it really all comes down to we should offer surgery early, and we should really try to maximize developmental potential for kids, and understand that trying medication after medication, while it may sound comforting and surgery may sound scary, we can show that surgery can actually help. But much more so in properly selected candidates compared to trying for many years for being on different medications. And then the concept of are kids too young for surgery? And in a international study, we put all of our patients together to show that actually operating in patients less than 3 months of age can be safe, can be feasible, and can actually have very good outcomes as well. But this is when you need to make sure that your surgeons plan well, and make sure that they have a lot of contingency plans. And beyond surgery, my group is leading a multi-site study that really is looking at comparative effectiveness, and it's for LGS. But part of that study is for me to ask all of you for help, because we're actually learning about functional outcomes that matter to families. So if you look at surgery literature, we can be like, well, we didn't lose a lot of blood, nobody got an infection, things went reasonably well, so that was awesome, right? And that was the way that surgery reports and surgery literature is, and now we're really learning, that doesn't matter to families. You want to know what's life going to be like after surgery, right? What is life going to be like? Are the seizures going to get better? Am I going to be able to tell when my child is in pain, right? Am I going to be able to say that we're going to be back to our community and our family? What's it going to be like for siblings? And so I'm going to distribute surveys actually through Monica and through our mailing lists, and we'll ask you guys for help, for some input, so that we can learn to do better. If we have a few minutes, I have 3 examples. Is that okay? Just kind of the putting it all together type of thing. This is a school-age child with Rasmussen's encephalitis, and really this is a good hemispherotomy candidate, right? So when I first started using the endoscope, I would say, well, I should probably do it open. This is a much more challenging case than a perinatal stroke. But since this came towards probably my fourth year of doing this type of surgery, we were able to do it with an endoscopy, and because this was a 9-year-old, we actually did not have any level of blood loss that would need an ICU stay, so that was about 30 cc blood loss. And then was able to start physical therapy really quickly. And for a Rasmussen's encephalitis, the waking up with a notable deficit right after, and that getting to rehab and being able to really start working on it is really important. So I think that enhanced recovery really gives something to work towards right afterwards. So not having that swelling and the pain and kind of feeling miserable. So it shows that's a good application. There are cases where it really is not clear, right? So this was another school-age child having up to 20 seizures a day, and seizures were coming from a stereo EEG recording and study. They were coming from essentially smack where the language area was coming, right? Where you need to understand, where you need to talk, all that. So that is not a good hemispherectomy candidate. This was not Rasmussen's, it was actually tuberous sclerosis. So we ended up, after doing the stereo EEG, putting in an RNS. And this is something that Dr. Adelson talked about, and also Dr. Taylor-Abel. And I think this is part of the evolution, right? This was not possible for us to offer 20 years ago or 10 years ago, and this is now a source of hope for patients and families. And in the adult studies, the long-term studies has been showing really very impressive results of about 75 to 90% seizure freedom for a lot of the patients. And our experience so far has been pretty similar in kids. So, and this will be the last one. This is actually a video that I promised. This was a toddler who had a hemispherectomy from a hemispheric cortical dysplasia. And had 6 months of seizure freedom after hemispherectomy, but then the seizures started coming back. So we thought, well, is there a residual connection? And since the child was very young at the time of surgery, that's when the brain is a little bit kind of softer at the time of surgery, and we do have to worry about a lot of blood loss planning and things. So when we look for residual connections, we need to identify where it is, and then we can think about, can we use minimally invasive approaches now? Other types of things to consider are, do we need to take out the whole hemisphere? Do we need to go to anatomic hemispherectomy? Or are there underlying genetic issues where the seizures are actually on the good side of the brain, right? So there's all of that in part of the workup, but if you can think about an area that's like really just the residual connection, then you can think about minimally invasive approaches, right? So when you look at this, we try to look at our imaging in all different ways, and if you can identify with tractography where the most common would be at the splenium or at the frontal-basal part, where there could be a residual connection. This is where we suspected in the splenium. So we were able to put in a laser fiber and target that area that we suspected, and that is really an overnight stay. So this is kind of what it looks like, where let's see, where we put in the laser fiber. We actually, it's a thermography and the MRI scanner where we essentially affect that burn. And then after that, you'll see kind of like our damage map with the orange is where the tissue is irreversibly damaged with the laser, and that is the disconnection that we're targeting. So even after you've had surgery, we can think about other minimally invasive ways to augment or help as needed. So yeah, but thank you very much for sharing this time with me, and it was really just such a pleasure and an honor to be able to follow you, Dr. Adelson, and actually give this talk in front of Dr. Amazing.